Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. This episode is sponsored by apnea. There was a recent consensus statement from the Society of Anesthesia and Sleep Medicine and the Society for Obstetric Anesthesia and Perinatology on the screening, diagnosis, and treatment of obstructive sleep apnea in pregnancy. Earlier this year, we spoke with Dr. Gada Borgelli, who emphasized the importance of treating obstructive sleep apnea during pregnancy. Unfortunately, there isn't a straightforward protocol that can be easily operationalized to do this. For too many, a sleep evaluation is deferred until the pregnancy is over, with the idea that pregnancy-related sleep disorders will resolve at the end of pregnancy. This leaves so many with sleep disorders undiagnosed and untreated. Dr. Louise O'Brien has tried to bridge this gap. She works in the Division of Sleep Medicine in the Department of Neurology, as well as the Division of Maternal Fetal Medicine in the Department of OBGYN at the University of Michigan. She is here to share her experience locally, but also globally, when it comes to sleep health during pregnancy. She has been involved in women's health research and sleep research for approximately 30 years. Welcome. Thanks for being here today.
Great. Thanks for having me.
So tell me about this consensus statement. I saw a few familiar names on that author list.
Absolutely. So the consensus statement came about from several of us who are working in this field, interested in getting standardized questions into electronic medical records of our respective institutions. I think these initial conversations were back in 2016, so quite some time ago. And after many discussions, we realized that we were, in a good position to think about a position statement that could be used to help guide clinicians for recommendations in the screening, diagnosis, and treatment of OSA in pregnancy, based on currently available evidence. So I think after a lot of planning, and by now we're kind of, with 2019, we basically divided into groups. Each of us took a section. For example, there was a screening section, a diagnosis section, a treatment section. And we worked to look at the evidence that was out there, going through all the published literature. We had, templates that we would use. So we were all doing it very systematically, in a very systematic way. It took a long time and it was a lot of hard work. And then we, wrote all of this up, and then ultimately this was published last year. So it was conceived in 2016 and it finally came to fruition, relatively recently. So I think that just, tells you what a lot of hard work it is to really review all the evidence out there.
Well, and how funny to use the term conceived.
Right. Very apt.
So when we first chatted with Dr. Borgelli earlier this year, it really seemed like a no-brainer to me to really screen for sleep disordered breathing and other sleep disorders during pregnancy. But why don't we do this? Why is this harder than it maybe initially appears?
That's a great question. And I think, change is hard, right? And implementing anything new is often a challenge, and it can be particularly challenging when you're working in large health systems. So to do something different, I feel that, people want data to show that adding more questions, for example, to clinical visits are helpful. What is the yield of this versus are these questions for, additional research? Because there's a different approach, right, for depending on which of those you take. So I think, additionally, clinic staff has to be trained to ask the questions. Who do you ask? Do you ask everybody? Do you ask those who are at high risk? And then when we have that information, what do we do with it? How do we figure out, to use those responses to triage patients to the relevant people, for example, to sleep medicine? And there are many places that don't have sleep medicine. So then what? So I think, it sounds really simple in theory, but I think it's definitely harder to do in practice.
So then tell me about your organization. Do you have maybe like a fast track referral system?
So we do. At the University of Michigan, we have a referral system for high-risk pregnant women to receive priority sleep referrals an evaluation. So we have a big sleep medicine program. We recognize that lots of places don't have one at all. So this obviously can't apply everywhere. But typically how we've tried to work it, and I will say it's harder than it sounds. But typically we will try and focus on women who, for instance, have high BMI, they're snoring, and it's also in the setting of hypertension. So in the work that we have done over the years, we found that that's a group of pregnant women who appear to be at the highest risk for OSA, as far as we've been able to tell. So that's the kind of, women that we think are, would be most beneficial to get those referrals.
So it sounds like you focus primarily on sleep disordered breathing rather than maybe insomnia, restless legs, that sort of thing. Okay.
Right.
Okay.
Right.
So, when you do screen, do you use a screening tool, or do you just kind of go by what you were talking about with snoring and high BMI and hypertension?
So the referral system, I think that's a double-sided question. So the referral system that we have is really for those providers, which tend to be maternal fetal medicine providers that have concern that, their patient might have obstructive sleep apnea. So those key questions, the BMI, the snoring in the setting of hypertension, those are the ones that can, drive that referral system that it's kind of built into, the electronic medical record. So that's how we really use that in a clinical way.
So we're asking the maternal fetal medicine people to identify the people they think might have sleep apnea.
Right.
Right. Okay.
Yeah.
Okay. So do they use stopping or Epworth or Berlin or anything like that?
No, it's typically just those 3 items. If they're positive for snoring, so frequent snoring, but BMI is over 30, and they also have hypertension, then those are the 3 criteria that our clinical group, can use to get that referral into sleep medicine.
Are those pre-pregnancy values or sort of at the time where they are seen?
They're at the time when they're seen. We've had some research projects go on. We finished a research project relatively recently where we were trying to develop a new tool because, as you mentioned, there are several screening tools out there, many of which have not been validated in pregnancy. And in fact, when they've been used in pregnancy, have been shown to not be particularly helpful. There's a couple of other groups that have also done the same and tried to do a pregnancy-specific screening tool. But there's nothing ideal. There's nothing perfect out there.
Okay.
And so we've tried to do that. We're sort of looking at the results at the moment. But, what we work on right now is just the BMI, the snoring, and the hypertension. That seems to be a relatively easy method. It doesn't take, 10 seconds to figure those items out instead of doing a complicated, screening tool and having to calculate a score and things like that, which again adds time to a clinic visit, which providers, don't want and don't have the time for. So I think if we can use some very easily and quickly accessible clinical things that, it'd be a little bit more efficient that way.
So you said something really important, though. You said that, stopping and Epworth are not great in this population.
Right.
That's really helpful, especially if we are using that as sort of, the do we refer or not.
Right. I think it's very important. We've actually looked at the Berlin questionnaire, which is another big questionnaire that's widely used clinically and for research purposes, most often in the non-pregnant population. And when we've looked at that questionnaire in the context of pregnancy, we found that it appears to be really picking up on the BMI more than, any sleep apnea in this population. So, that's not something that we have ever done clinically, is use that questionnaire. And I think with the Epworth, because that is, screening for daytime sleepiness, I think the caveat to remember in pregnancy is that people are sleepy for different reasons, right? There's a hormonal component to daytime sleepiness in pregnancy. So that might be one of the reasons why it does not perform very well in this population.
And is that, and I don't know if they've looked at it in this granularity, but is that something that changes throughout the pregnancy? Meaning that maybe it is a little bit more, similar to non-pregnant cohorts early in pregnancy versus later, where maybe it's picking up more in the BMI?
I mean, it could be. And I've always believed that, we shouldn't be just asking these questions one time in pregnancy because pregnancy is a dynamic state, right?
Right.
It changes. And as a physiologist by background, when I got into this field, gosh, a long time ago, maybe pushing 20 years, unfortunately. I was kind of puzzled. I mean, there wasn't very much out there at the time that I became very interested in sleep and pregnancy. It was actually a publication by Dr. Colin Sullivan in Australia that got me very interested in this field about 20 years ago. And I realized that, why is nobody doing this? This seems to be a really important area. It's impacting not only, the mother, but also the offspring. And so that kind of really got my attention with the work that was being done in Australia. And I became interested in, in the half a dozen publications at the time that were out there, why are we only asking these questions at delivery? Now, I get it. It was a research environment at that point, right? But it didn't make sense why we're just asking, did you snore in the last week of your pregnancy?
Okay, so tell me more about that. That was what that paper was? It was
there were a couple of papers out in the literature at that point. And they were asking about, did you snore in the last week of your pregnancy? And those were some really important papers because they got the field, they started to publish in that area and it got people interested. But it made me think, pregnancy is a dynamic state. Why are we not thinking about this a little bit sooner? So when we kind of launched some studies here at the University of Michigan back in, it must have been about 2008, even though we were, we had very limited funding at the time, we were recruiting women in late pregnancy, like in their third trimester, but I added a question about their sleep prior to pregnancy.
Oh, okay.
Because that made sense to me that these things might change. They might have differential impact. Who knows? Like, why not just ask the question?
Yeah.
And so that's what we did. We had a question in there and the results, this study went on for several years and the results were so interesting to me. So what we found was that women who had there was three groups of women, essentially. We had women who were non-snorers throughout the pregnancy. We had women who were chronic habitual snorers. So they'd done this before they were pregnant and they continued into pregnancy. And then we had the pregnancy onset snorers. And so when we looked at the maternal outcomes in terms of, hypertension, what we found was it was actually the women who developed these symptoms during pregnancy that was driving the association with high blood pressure.
Oh, wow.
But then when we looked at the baby outcomes, we found the opposite, right? So we found that it was the women who had these symptoms prior to pregnancy, their babies were born a little bit smaller. So that made me think, gosh, what's going on here? And the only way I can, think of an analogy is almost like, when you're pregnant and you get hit with this challenge. And so in this context, it's the habitual snoring, the sleep disordered breathing. When your body's hit with this challenge in pregnancy, mid-pregnancy, let's say, it doesn't have enough time to adapt. And maybe the outcome is then mom's blood pressure goes up. However, if you enter pregnancy already having symptoms, already having, sleep disordered breathing, maybe that embryo, that fetus doesn't really get a chance to develop into its potential. And that's why it's born small. So that's kind of how I've kind of rationalized it in my mind, rightly or wrongly, but that's how I've tended to think about it because it physiologically makes sense when I think about it that way. And so this is why I do believe it's important to ask the questions early on. Do we screen for sleep apnea early on? But then ask them again, right? Because pregnancy changes, you gain weight across the course of gestation, and things change. And so I think asking that question once is not enough.
That is such a good point. And it is, for anyone who's tried to add a question to an existing questionnaire at a facility, that's hard to do.
Right. And I think that's part of the challenges that, we've been up against. And I also think, if you're going to be adding things into, electronic medical record systems, there needs to be a yield, right? You need to know what you're going to do with it, and is answering those questions, is that going to change how you care for that, that patient? So it's not as easy as just to say, let's add a few questions, right?
Well, but that's true, right? Because it probably would change your management, certainly even just the frequency of asking the question. But then, at what point do you do a test? And, is that a home test typically?
That's another great question. I mean, I can, speak for our sleep lab here, is that we are busy. We are large, but we are busy. And it is difficult to, can you see somebody in clinic and then get them in the same week? It's very challenging. Sometimes there can be months, for a wait period to get a sleep bed. And this is a population of people that don't have months, right? Time matters, because pregnancy is going to wait for nobody. It's going to keep going.
Right.
And so, I think home sleep testing does have a role. But then there's also the argument of, how accurate versus, in-lab polysomnography. But I do think it has a role, at least in the situation where, time waits for nobody.
So then we don't want to screen every pregnant person who snores, right? Or at least I should say that we don't want to test every pregnant person who snores, right? Okay.
Right. Because I think, screening, yes, we can ask the questions, we can look at the risk. But I think it would be just impossible to test everybody for many different reasons. I mean, for one, you'll overwhelm a sleep service, right? Yeah. Even if you have one, you have to have one first, but then you would overwhelm the sleep medicine service. And then for what yield? Because, we believe that obstructive sleep apnea, so objectively diagnosed OSA in pregnancy, probably affects about 10%, maybe up to 20% in the general population. I mean, those studies are limited. There aren't very many of them. What we do know from a couple of other studies, including ones that we've done here in Michigan, is that in women with preeclampsia, it's usually about 40 to 50% will actually have underlying obstructive sleep apnea as well.
Wow.
So again, it's a different, in general, 10%, maybe 15 or 20, but in these high risk women, certainly the frequency of OSA is higher.
Do we define sleep apnea in pregnancy with an AHI of 5? Like what is a normal AHI during pregnancy?
Oh, that's a great question. So, I don't know that I can answer it, but, in adults, the threshold for OSA is an AHI of 5, right? And in children, it's much lower. So my personal feeling, and this is, my personal opinion, it's not based on evidence, but I personally feel that the AHI threshold in pregnancy is probably lower than 5. I have no data to go on to tell you that, but that's my gut feeling. And, we won't have those data until those big objective studies have been done and we've looked at outcomes. So, maybe, the new mom-to-be study that has been conducted, maybe that study will be able to inform us of what the outcomes are, both maternal and fetal outcomes, whether you have an AHI 5 or an AHI of 2, or maybe it's an AHI of, 2 or 3 with oxygen desaturations. Maybe that's the key. So I think we need more data, we need large samples, and we need to look at not just the AHI itself, but also, the desaturation data and how they relate to outcomes. And I think only then will we have a better sense of what should this threshold be in pregnancy.
Yeah, because you're right. I mean, that there's so much more nuance, I think, right? It's not just bluntly an AHI of 5, an AHI of 5 for somebody who has 10-second events and no desaturations, in my mind, is very different than an AHI of 5 where the events are 45 seconds and you desaturate, to the 80s.
Absolutely.
Right? They both have an AHI of 5, but in my mind, very, very different.
Very different. I agree. Absolutely. I agree. And those data just don't exist yet, but I think they will be coming.
Wow. Okay. That's good to know. So let's take a short break. And when we come back, we'll talk more about pregnancy-related sleep disorders. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apria Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apria Healthcare. Discover more about our innovative sleep program online today at apria.com.
Welcome back to Talking Sleep. We're talking with Dr. Louise O'Brien about sleep apnea and pregnancy. So I was at the Michigan Sleep Conference last month, and you gave a great talk on sleep and pregnancy. In fact, after your talk, I emailed my friend and I said, please introduce me. Please introduce me to Dr. O'Brien because I really want to pick her brain on this. And one of the things that I came home and actually talked to my husband about was some of that placental data that you present. And I'm wondering if you can share that with us.
Yes, it's very interesting. I mean, there's not very many studies out there on the, OSA and the placenta. I mean, Dr. Bourgeli has published a couple of them. We have some data that we haven't yet published, which I do need to get out there. It's always the same way, lots of data, right?
Right.
So I think what's important with the placenta is, the placenta is the connection between the mother and the baby, right? So this is such an important organ that just gets overlooked in terms of sleep in pregnancy, I think. And so what we know so far from the literature is that there are markers of tissue hypoxia and markers of angiogenesis that are more common in placentas of OSA women compared to controls, so women that didn't have OSA. What we have done in, a group of, placentas that we've had access to from women who have undergone sleep studies for various research protocols that we've had running, is we found that the fetal placental weight ratio, which is a common metric of the balance between fetal and placental growth, is reduced as the severity of OSA increases. So as you kind of go from no OSA, mild, moderate, severe, that fetal placental weight ratio goes down.
Meaning the fetus is smaller or the placenta is smaller?
So that would mean that the fetus is smaller than the placenta.
Okay.
Yeah. So in addition, we've also seen that the chorangiosis, which is an increase in the number of the vessels in the chorionic villi, and it's likely a result of a hypoxic stimulus, is increased in women who had OSA compared to those that didn't. Interestingly, we've also seen that when we've looked at women who were treated with positive airway pressure, the chorangiosis in those placentas was more on a sort of control kind of level. So these are, super interesting data that's telling me that something is going on in the placenta, with these women. The other thing that we've seen in several cases, actually, we've had women who have had very poor obstetric outcomes where, maybe they've lost babies sort of mid-pregnancy, they've had preterm deliveries, and then, they're pregnant again and they've come into our study, and we had a study where we were giving women positive airway pressure therapy. Like I said, we've had a few of these cases where women have come into this study and they've actually done pretty well. They did not develop the high blood pressure that they'd had in prior pregnancies. The pregnancies had progressed to the point that they'd had, a great delivery. They'd been able to take a baby home. And when we've gone back to look at those placentas, very interestingly, their placentas were normal, except for maybe a tiny infarct that looked like it could have become a preeclamptic looking placenta. And the only difference that has happened between these pregnancies is we've had women on positive airway pressure therapy. So
Wow.
our sample size is too small, right, to say anything about it statistically, but it has got me very excited that maybe the positive airway pressure therapy is doing something important to the placenta. That placenta looks much more normal, than it did in the prior pregnancy. So I'm very excited about the potential for positive airway pressure therapy as a tool in an obstetrician's toolbox, if you like, for those patients with sleep apnea during pregnancy. I think it's something that we need to screen for, we need to treat, and we shouldn't be waiting until after delivery. I think we've missed a critical window if we wait till afterwards, for both mom's health and for the baby's health.
Just so I understand, all of the women in that study had sleep apnea that was diagnosed at some point during that study?
Not all, but they all had hypertension.
So that's interesting to me. So even without a diagnosis of obstructive sleep apnea, they were treated with PAP and had good outcomes.
Correct.
So there's something in there, right?
There's something in there. Exactly what? I can't tell you, but there's something in there. And I think, these studies need to continue, and we need to look at mechanisms, and, we need to be taking blood. There are a couple of case reports out there where they have taken maternal blood samples and showed some improvement, in some of the biomarkers on PAP therapy. So I think, together, all of the evidence, if we can, look at it together, it's certainly pointing in the right direction. Is it enough to, make a guideline? I don't think we're there yet. And I think that, that consensus statement kind of, suggested that we do see some positive outcomes, but I just don't think the strength and the quality of the evidence is there yet. These are not randomized controlled trials, which is the gold standard, right? So we don't have those yet. But I think that's the way the field is going. And, hopefully in the next several years, those data will become stronger.
Well, Dr. Bourgeli said that preeclampsia was determined biologically at week 11 to 13, and that screening early could modify that biology. So that kind of fits with what you're sharing, right?
Right. Absolutely. Yep. I think if we can screen early, we have the potential to alter the trajectory of that pregnancy.
So, when you talked about age and BMI and hypertension, what about a patient who has a history of preeclampsia? I mean, should they be screened either, prior to pregnancy, early pregnancy? Should they have a CPAP during pregnancy?
That is a good question. I would say that, yes, we should be screening those women because those are high-risk women. We have seen cases where women have, been on PAP therapy in pregnancy, have come back, with a subsequent pregnancy, have still had high blood pressure, no longer using a PAP, and then have had poor pregnancy outcomes in the subsequent pregnancy. Can I say that is because they weren't wearing the PAP? Absolutely not. But I think that these kind of anecdotes that we see, we're starting to see a number of those. And I can't help thinking that potentially we could change the trajectory, but we just don't have the data to show that yet. But I do believe that it is possible.
It's funny because we were always taught that pregnancy is a window into the future, right? And so when I have a new patient, I usually will ask about their sleep during pregnancy, if they have had a pregnancy, and ask if they snored and ask if they had gestational diabetes and gestational hypertension. And it really is kind of interesting to see that correlation. Obviously, anecdotal. Right. And I'm asking because I'm looking for that. So that's also not really a fair way of doing it.
Right. But I think we do know that, things like gestational hypertension, gestational diabetes, preeclampsia, all of these things we do know, can put women at a higher risk for cardiovascular disease in later life, right? So that's a known. And the way I think about it is, okay, we have a window of opportunity here in pregnancy, that if we can alter that woman's, hypertensive disease or her diabetes, maybe when, we're actually helping her longer term health too. Maybe we can reduce her risk of cardiovascular disease in later life.
I mean, it just feels like such a sense of urgency, right? Like this is something where we have this window, like you've said, and is this a modifiable risk factor? And how can we collaborate and maybe be more thoughtful about how we create a program like this? Like if we have a screening program, where should that live? Should that live with OB? Should that live with sleep? Should that live with anesthesia?
I do think we should have a screening program. And I think, on the surface, all three of those places would be great. But going back to our earlier, conversation, I think that the sooner we do it, the better. And, what better place to do things sooner would be in OB when people present early in pregnancy for the most part. If we leave it to maybe anesthesia, which is still very important because you want to know that risk of OSA before maybe a C-section or, any kind of anesthesia, right? Maybe it's too late to change it then, because maybe anesthesia isn't getting involved until the 3rd trimester, planning for a C-section, or maybe even at delivery. And by then, okay, we can identify it, but how can we change it? Maybe it's too late to change it at that point. And I feel like in sleep, we already know it's important. And by the time we need to get women to get into the sleep service, which is, I think, the difficulty, the challenge.
Is there a reason that the HSAT devices couldn't just be deployed through OB and then read by a sleep person and then, maybe handed off to sleep?
I think, again, that sounds very easy to do.
I know.
And in practice, there's a lot more that goes on behind the scenes to make that happen. But we've certainly, been in talks about that potential. We're not there yet, but it does seem relatively simple. I hate to use the word simple when we're dealing with, referrals and things like that. But it does seem relatively straightforward that we could potentially introduce something like that, and at least get women, triaged. So those that really need to be seen can be seen. But that's an ongoing conversation. I think it's an important one. We're just not quite there yet with, all of the things that need to be in place to make that happen.
Yeah, I mean, it's so funny because for so many years we've talked about how important it is to raise awareness of sleep disorders. And we've, really tried to be thoughtful about our interactions with primary care, for example, right? Or with endocrine or something like that. I'm not sure that we've made those inroads with our OBGYN colleagues, though.
Right. I agree. I think, so OBGYNs are seeing, obviously there's a lot of things they have to ask in a short visit. So I think this goes back to the beginning about the data, right? What's the quality of the evidence? What's the strength of the evidence? And I think if we have those kind of strong, high quality data there, then it makes it a little easier for things to be rolled out in the OB system. I think without that, it becomes a little harder to do. I think that's the big challenge.
I remember hearing one of our colleagues, Andrea Ramberg, speak on pregnancy and sleep. And she had pulled up this table of how pregnancy, people who are pregnant, that so many people feel like they have the right to either touch or judge or, have really provide unsolicited advice for. And so they kind of had this list of who gets judged the most frequently, and they had like rapists and murderers and all of these things. But a pregnant woman was really high up on that list, which kind of led to this conversation about we want to improve their sleep quality, and not in a way where it just feels like we're picking on them and adding more stuff, right? Like, oh, don't have that caffeine, and oh, what are you putting in your mouth? And oh, is that medication okay? All of these sort of parts of it. But I feel like if there's education around how important it is for the mom in the future and the baby, I wonder if we could frame it in a way where we're not just throwing one more thing for a pregnant person to deal with, but rather how can we make your life better by really, how can we help you? How can we partner?
Right. It can be a hard sell, right? I think pregnant people are very judged for all the reasons that you've said. But I do think it comes down to education. And I think that, a lot of healthcare providers are not educated about the importance of sleep. And that's a problem. Medical students don't get a lot. I mean, in prior years, didn't get any education on sleep. And yet the fascinating thing about sleep is, both of us here know that, it is so important in many, many areas, if not all areas of medicine. That's the beauty of sleep, is it affects all of us. And I think all, medical specialties could potentially benefit by understanding a bit more about the importance and the need, for sleep. So I think education is absolutely critical. And we do try and do that. We do try and do, community-based sessions on the importance of sleep in various populations, not just in pregnancy. But this is a topic that is so important and so amenable to education. And I think people want to find out more about it because we all do it, right? It's not just something that 10% of the population do. We all have a need to sleep. So I think being aware of, how suboptimal sleep can negatively impact our health on many, many areas of health is very important.
And this is not a uniquely American phenomenon.
No.
This is a global problem. So what I'm wondering is, are there other interventions that we could apply broadly during pregnancy? And I'm kind of thinking about educational programs that came out to encourage new babies to sleep on their backs. Is there something similar that we should be advising during pregnancy?
Well, I think that the problem, I think, today is that we live 24/7, lives, right?
Right.
We have electric light. We stay up till, 1 o'clock in the morning doing things because we can switch a light on. We can see what we're doing. But our body hasn't advanced the way that, our lives have advanced, right? So, our body needs sleep, and it has a circadian rhythm. And, we shouldn't really be shining bright light, into our faces at 2 o'clock in the morning. And I think that's a problem, right? There's lots of research out there on the importance of, circadian rhythms. And it's, I could talk for a long time about all the different facets of sleep, but I think understanding our circadian rhythms is so important. And yet, how can we balance that when we live in a 24-hour society? It's very difficult. And shift workers, right? I mean, shift workers are working at night against, for the most part, their biological rhythm. And we see that the incidence of, things like, cancer is higher in shift workers. And there's a biological mechanism for that, with the disruption of circadian rhythms. So there's lots of areas of sleep that are critical to our long-term health.
You pointed something out during that talk, and I feel really silly for never having thought of this during 2 pregnancies, but just even having red light when you're changing your baby.
Right. And that gets at, the circadian component, right? So, like we said, it's not all about sleep apnea. Light is a problem. Light can disrupt our melatonin rhythm, right? We don't want to suppress our melatonin at night because we want to be asleep and we want to sleep, appropriately. And so I didn't know about this with my first child. I knew about it with my second child. So, I changed my lamps to red lights in the bedroom at night because the red light doesn't disrupt your circadian rhythm, right? It doesn't suppress your melatonin. And so if I needed to get up in the night and, change baby, I felt comfortable switching a lamp on that had a red light bulb in it because I knew it wouldn't disrupt my melatonin rhythm, and yet I could see sufficiently for what I needed to do. So little things like that can make a big difference. I'm sure it probably also helped the development of the baby circadian rhythm as well, right? Because it wasn't suppressing the baby's melatonin either.
Oh, that's a good point.
So, these are just little things that, that are kind of important, but how often are we talking about them?
Well, and this is, it's a huge problem. So what I'm wondering, are there other interventions that we could apply broadly during pregnancy? So I'm kind of thinking about like the movement about encouraging new babies to sleep on their backs, right? Is there something like that we should be doing during pregnancy? We should be telling our patients?
Right. So I think that, a lot of people have probably seen in the media in recent years that there's been a big push to recommend that pregnant women don't spend time supine, right? So on their back during pregnancy. So kind of the opposite, for the babies. And this has come about from studies in New Zealand, in Australia, in the UK, and we did a study in Ghana. And all of these studies were done all over the world, and they all pointed at the same thing, that women who spent time supine in their third trimester were higher risk of having a fetal demise, so a stillbirth in the third trimester. All of these studies, except the one we did in Africa, were kind of cross-sectional, meaning that they had two groups of women who had recently lost a baby to a stillbirth and those who had had a live-born baby, and they'd gone back and asked them about their sleep on the night before the event and the week before the event. The study that we did in Africa, we just went to women who had had deliveries, and we didn't know what those outcomes were, whether the babies were live born or not. But we asked about their sleep in the third trimester. And despite that kind of different angle than the other studies from the other countries, our findings were the same.
Wow.
So, women who usually spent time in the supine position had a higher chance of stillbirth. So, there's a big push at the moment to look into this. It's biologically plausible, right? Because of the compression of the inferior vena cava when you're on your back in pregnancy, so maybe that blood flow doesn't get to the placenta as well as it should. So it's very biologically plausible. There's a mechanism behind this. But we don't have the objective longitudinal sleep data yet, but those studies are ongoing. So I think we'll be seeing more interesting data, in the next couple of years. But it's very interesting to me that, for medical procedures such as like a C-section or even, like an MRI, for instance, women are not placed in the supine position. They're tilted onto their left side. And yet we're not translating this to what people are doing every night when they go to bed. So I think there's an awareness that we don't place pregnant people on their backs in late pregnancy for physiological reasons, but nobody's really thinking what's happening every night for multiple hours, right? So it's biologically plausible, like I said, and we should be aware that maybe side sleeping, especially in the last trimester. I think earlier in pregnancy, there's no evidence that it's a problem at all. But in the last trimester, because of that, large gravid uterus, you can imagine pressing down onto the big vessels, the inferior vena cava in particular, can compress those vessels and reduce the blood flow. And so it makes sense why babies might be smaller, or unfortunately, may result in a tragic outcome for some potentially more vulnerable babies. So I think that's something that we can all practice, is try not to fall asleep, on your back in the late stages of pregnancy.
Wow.
Of course, you don't know what position you sleep in, right, at night, but there are a couple of studies out there that show that the falling asleep position may be the most predominant position during the night. If that's true, then it would make sense. If you fall asleep on your side, that might be the most predominant position you'll have. So we don't have data to say how much supine sleep might be, potentially bad or have, result in poor outcomes. We don't have that data yet. Those are things that have been worked on. But I think it makes good practice to settle down to sleep on your side.
Wow, that makes so much sense. And plus then you're waking up all the time to pee and then
Right.
go back to sleep. So then, maybe don't go on your back. Yeah.
Right.
That's very common sense.
Right.
So what would you like us to remember about this episode? Do you have a key takeaway for us?
I would say sleep is a modifiable risk factor for poor pregnancy outcomes. Maternal sleep is hugely important to the health of the mother, the health of the baby. But sleep is a modifiable risk factor. I think that's the key take-home point. We can change sleep. We can treat clinical sleep disorders and we can improve sleep behaviors, such as the supine sleep. So it's modifiable. We can change it.
Wow. Well, thank you so much for spending time and sharing your expertise with us.
Thank you for having me.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.